Hello and welcome to BoneUP, the podcast all about bones. I'm David Armstrong.
Hi, and I'm Richie Abel, and we're going to bring you the latest in bone research. So whether you are a patient living with a bone disease, a family member, or a healthcare professional, you've come to the right place.
If you want to learn more about your infrastructure of calcified collagen, this is BoneUP. Hello and welcome back to another very special episode of BoneUP. We're live here at the European Calcified Tissue Society meeting in Girona in northern Spain. And I hope in this episode we bring you another flavour of the wide range of talks and presentations and items for discussion that we enjoyed today. So, listeners, we are delighted to welcome back a former interviewee of the podcast and friend of the podcast, Friederike Schulte, and she spoke to us not last year but 2 years ago at ECTS about some very exciting work she was doing. Well, you can maybe tell us about it, but we were excited to hear the use of osteoanabolic agents in the mice you were looking at, and we talked about sending mice to the gym, if you will remember. So tell us, you've got some exciting news about that project.
Thank you. No, I'm very glad also to be back and be here at the podcast. And the exciting news are that the paper is now published.
Congratulations.
And thank you very much.
We like to feel your appearance in the podcast was seminal in that.
Indeed. And it was quite a journey, and that was a long, also a steep learning curve. It's now published in Nature Communications, and I remember very well when we spoke in 2023 the first time about our result. It was about the combined effects of when you combine pharmacological osteoporosis therapies with physical exercise. In our case, as we are in the preclinical field, we work with mice, therefore it is mechanical loading that we call it as a surrogate of then physical exercise. And at that time already we saw in the bone volume fraction and static and also dynamic parameters that there might be some synergies or at least additive effects when we combined mechanical loading with anabolic pharmacological therapies, but we did not see those effects in the bisphosphonate treatment. And I remember very well when you asked me the question about the bone strength. And at that time, I did not have the bone strength. But I went home from the Congress and I thought, this is a parameter that we really have to look at. And we did that then with microfinite element analysis. And indeed, it turned out, at least for the sclerostin antibody treatment, that strength was indeed the parameter where we saw the synergistic effect when the mechanical loading was combined with the pharmacological.
And by the synergistic effect, you mean not just, it's like 1 + 1 = 3, isn't that right? So you get the benefit from the mechanical loading, from the exercise, we hope. You get the benefit from the pharmacology, but you seem to get like a double benefit when you put the two of them together.
Exactly. You can also test that statistically. So you would expect an additive effect of combining the two treatments. But if you get a significance, that would mean that the effect is more than the effect of the...
Each one separately, yeah. And I think we talked, if I remember, because it was a few years ago now, about how you were adding bone in just the right place. Wasn't that right as well?
Exactly. That's also the principle that was proposed long time ago from Harold Frost at that time, who suggested that bone could also have something like a thermostat, that it is able to control its bone mass on its own by adding bone where needed and resorbing bone where not needed. And because it was or has been difficult in the past to assess this question with experiments for a long time, this was predominantly, or this research question was predominantly investigated by in silico models, which also gave great insights. But here, with these experimental data, that was like for us, the chance also to investigate that, looking at experimental data.
Fantastic. And how much of the improvement in strength is due to the increase in the bone mass versus putting the bone in the right places?
That's a very good question, because we saw that looking at initial bone mass and then how much increases in strength we would get, there was not a high correlation. But what we saw was when we looked at modeling and remodeling based bone formation, and then we saw that the more modeling-based bone formation a drug is able to complete, to produce, the more increases in strength we get in the, I mean, we look at the trabecular compartment, and I think there is something. So, if the bone is able to add fast bone material at the site that is the most highly loaded, then the fracture risk is reduced.
So you're by putting pressure on certain parts of the bone, you're almost encouraging new bone tissue to be built in that area.
Exactly.
Because that's very exciting, and that's something that patients would actually love to hear, that if you're just injecting a drug, for example, but if you're going and loading your bone, then the body seems to know to use that drug almost to build bone in the weaker areas, which is, that's really exciting.
Yeah, and what we saw was in the weaker areas, within one bone, so really at the tissue level. Because the loads are transferred through the trabecular microarchitecture, and there in that particular site where the loads are high.
And just to emphasize, you were seeing these benefits primarily with the osteoanabolic drugs and not so much with bisphosphonates anyway.
Exactly, because bisphosphonates are very well able to reduce the bone resorption. But imagine a site, a trabecula that is highly loaded, but the only ability of the drug is to reduce bone resorption. This wouldn't help much in that sense.
This is the most exciting research I feel that we've seen at ECTS in the last few years. What's next?
It's for me, I come from the computational field, and because this problem to see how the mechanostat or whether we can tackle the mechanostat is something that computational models have for a long time tried to investigate. And so the next step is now to see how to use those data. They are out now, they are fully accessible, and to use those data and to see whether the computational models that we have developed, whether they could reproduce the data that we have from the experiment. And I hope that these experimental data can then serve as a kind of a reference.
Fantastic. A lot of us in the mouse biomechanical testing world would really appreciate that kind of useful data for us to be able to validate our models as well.
Thank you for taking the time to speak to us. You're really becoming a friend of the podcast.
Definitely. I love it. Every episode that is posted, I also have to listen.
That's great. Thanks very much.
Thank you.
Thank you.
Listeners, we're delighted to bring to you our next guest now, Mathilde Palmier. Welcome to BoneUP.
Thank you.
It's a pleasure to speak to you. We're looking forward to hearing you tell us about your research.
Thank you.
Would you be able to give us a quick explanation about your poster at ECTS?
Yes, so my poster is about glucocorticoid treatments. So when I arrived in the lab, I got involved in this project because there is an ongoing clinical trial which is looking at why high-dose glucocorticoid can trigger secondary osteoporosis in some patients, but don't in some others. So in vivo glucocorticoid at high doses can actually impair the osteoblast differentiation, so the bone formation, and trigger adipocytes differentiation, so increase the fat inside the bones. And I have been involved in this project for the past year and a half, and have set up the whole biobanking of the cells coming from the patients in the hospital to then be able to do some experiments in vitro. And these experiments that I will do will be a validation of something that has been done before on our immortalized cell line, which is called HMSC 34, and in which my colleagues looked at why, if glucocorticoid can be deleterious to osteoblast and differentiation and bone formation in vivo, then do we need glucocorticoid to actually differentiate these cells in vitro? Mm-hmm. Yes.
Yeah, it's quite a conundrum, that, isn't it? Thinking that it could be toxic in one sense and vital to life in another sense.
Yes, so the first thing that we have looked at is the concentration, because I told you that high-dose glucocorticoid can trigger secondary osteoporosis. So, and we have an optimal dose in vitro to trigger the differentiation, but there is also a high dose when the differentiation is actually impaired. So then we digged deeper to see why the high dose is actually impairing the differentiation. We looked at day 1, and what we saw is that the high dose is not really a problem at the very early stage of the differentiation. The glucocorticoid is just telling the cells that they need to differentiate. Mm-hmm. And now what we are doing is looking at later stages, because we saw some signs that the differentiation is actually impaired at later stages during the osteoblast differentiation.
What stages of the differentiation do you think you're starting to see the negative effects?
So the transition from 7 days of differentiation to 12 days, that's when we actually see the biggest gap in the differentiation.
Any ideas why you're seeing that gap at that time?
We have run some transcriptomic analysis. So for now, at the level of gene, we see differences in regulation of metabolism pathways. So we have method in the lab to look at the metabolism. It's also what I have done before coming to the lab. So this is what I'm going to investigate in the future, and also in the primary cells that I mentioned in the beginning.
And is that something would translate directly into the patients that I see when you say that sort of 7 to 12 days? So if a patient starts to take steroid tablets, glucocorticoids, because they've got asthma, they've got rheumatoid arthritis, we always warn them, this could be bad for your bones, you could develop secondary osteoporosis. So you're saying it's sort of a week or 2 weeks before you start to affect the osteoblast building new bone, or can we not translate it as directly as that?
We cannot directly translate it, because in the bone there are osteoblasts at different stages. Okay. So there are the mature osteoblast, and the glucocorticoid can already have an impact on this mature osteoblast. And now, right now, I'm looking at the differentiation. So
you're looking at the sort of the baby cells to start off with. So it takes maybe week, 2 weeks to have an effect on those, but if you happen to catch an osteoblast that's a bit older, it could have a much faster effect on it.
And a completely different effect, yes.
Okay. Yeah. Because there's one question I think we always ask: if a patient takes steroids, how does it make how does it affect the bone? And sometimes we would have said to patients in the past, it makes the osteoclasts work more, and other times we would have thought, no, it stops the osteoblasts from working. So this is very much on that side of the equation. It stops the osteoblasts, but potentially it also creates more fat cells inside the bone, in the bone marrow.
Yes.
And that might cause inflammation, which might stimulate osteoclasts, or am I jumping too far ahead?
I think it's plausible. Yes. And the thing is, there is this impact on the differentiation. So is the baby cell becoming a more mature cell?
Yes.
But also it can deplete the number of baby cells, because if we consider that these cells are actually can become both, adipocytes or osteoblasts. If they become more adipocytes, then we will have
there's fewer osteoblasts, because these are cells that can turn into either osteoblasts or adipocytes because they're stem cells.
Yes.
Yeah, that's.
It sounds like a really fantastic project, not only because you're going to learn something about how glucocorticoids might be related to osteoporosis, but also because you're improving the methods that you're using and other people are using in cell culture. And ultimately, you're linking it all the way back to a clinical data set in the biobank. That's absolutely amazing. And I guess the question I would ask is, in the future, if you can collect these cells from patients and biobank them, is there a way that this could be used clinically when doctors are making decisions about patient care?
You mean that we do biopsies, we test the cells, and then we go back to diagnosis? Yeah. I mean, the ultimate goal is to not have to do a biopsy, to look at biomarkers, but that could be a first step if we find something in the bone marrow serum which is more prominent than in the blood, for example. Yes.
We often hear about bench to bedside research, but actually this is bedside to bench.
Yes.
Thank you for your time today. That was really fascinating and very well explained. Thank you.
You explained that really well. Thank you. Enjoyed that.
Thank you for having me. Yeah.
Listeners, we're delighted to introduce our next guest, Melina Guillon. Welcome.
Thank you for having me.
So we met at the Danish Bone Research Society, which is, I think, bone's best kept secret.
Mm-hmm.
On Monday, you're going to give a talk about your research.
Yes.
Would you be able to give us a little overview about the work that you're going to present?
Yes, so in my research, we are investigating the potential of a drug that is used clinically to prevent the rejection of organ transplants, and also it is an anti-cancerous drug. And in this project, we are investigating its potential to prevent bone loss that women experience when they transition to menopause. So in my project, we are looking at human cells, but also mice, and we combine this data to get a better idea.
Well, that's exciting because we've been hearing a lot about repurposing drugs because these drugs are already licensed and available and manufactured, but these drugs are used at the moment for something completely different to prevent rejection of organs after transplant, but you think they may save bone, is that right?
Yes, exactly, and it can sound a bit scary, but in this context, it is used as very high dose every day for many months, and this is what we know about the drug.
And that's when it's used to prevent rejection? It's a high dose
Yes.
drug, but you're looking at it at a low dose, is that right?
Yes, at a low dose, optimally it would be few months only, maybe once a week in humans, and yes, right now, we know that it has positive effect on several organs in humans. It also increases the lifespan of different animals, including mammals, like mice. But we don't know the effect on bone, and we really need to investigate some potential preventive treatment because there is a lack at the moment.
And what experiments are you doing with the mice then to show that it might work?
What we do to the mice, it's we try to mimic menopause by depleting the estrogen level in the mice, and then they become osteoporotic, and the drug is given before that or right after this procedure, and then we look at what happens after a few weeks.
Okay.
And what kind of variables are you going to measure in the bone to try and capture the effect that rapamycin has on the tissue?
A bit like for humans, you do all kind of scans. You also look, so you have some radio, you look at bone density, bone mass, all these things, and then we look also at the cellular level and also molecular level. So we take some biopsies, and we look also at all these kind of things.
And what do you think the mechanism of action for the drug might be?
So this drug is an mTOR inhibitor. So mTOR, it is a evolutionary conserved pathways, so in animals, humans, and it is an anabolic pathway. So it promotes growth and development and differentiation. And when it's overactivated or constantly activated, it can prevent the opposite mechanism, which is repair and clearance in the cells. So this drug inhibits this anabolic pathway, which is allowing the cells to repair. And in animals, it has been shown to increase their lifespan and improve their function.
What do you think it will do for bone?
For bone, in our data, we can see that the inflammation in the bone is decreased. It also increased bone formation and angiogenesis, which hasn't been reported before in this tissue.
So it stimulates osteoblasts, is that right?
It stimulates osteoblast function, yes, and decrease osteoclast activity as well.
That's
yes.
exciting.
And angiogenesis, which can be also a mechanism responsible for the prevention of the bone loss that we observed in the mice.
Well, we're always interested to hear about potentially new drugs for bone. It's always interesting to hear about drugs acting through a different mechanism, potentially. And of course, this is a drug which is already manufactured and available. So the exciting thing about that is one presumes if it was shown to be useful, then it might get to the patient more quickly.
Yes, and in our group, we are actually running a clinical trial with postmenopausal women who take this drug once a week at a low dose, and we are getting the result very soon.
Oh,
so
that's really exciting.
we will know if it completely works in humans as well.
Okay, we're going to have to catch up again at ECTS 2027, and you can give us an update. That's wonderful research. Thank you for sharing it with us.
Thank you for the opportunity.
Thank
to
you,
present.
Melina. That was really good and really well explained. Thank you.
Listeners, we hope you've enjoyed the episode brought to you from Girona ECTS 2026. Stay tuned for the next one, which will be out soon.